Welcome, everyone. Thank you for joining the OAI CORE Knowledgebase's OAI.edu live webinar. Today, we are joined by Dr. Grace Lowe, who is an associate professor at Baylor College of Medicine. The title of today's talk is Lifetime Leisure Physical Activity Questionnaire in the Osteoarthritis Initiative. And following the presentation, we should have a few minutes for Q&A. So if you have any questions during the meeting, feel free to type them into the chat at any point, and we'll try to get them at the end. Without further ado, I will let Dr. Lowe take over.
Thank you, Julianne. And thank you everybody for joining us for this webinar. So as Julianne said, I'm going to be talking about the Lifetime Leisure Physical Activity Questionnaire, which is included within the Osteoarthritis Initiative. So my objectives for today are to talk about how this data was acquired, how to access it now, what can be done with it, what has been done, and analytic strategies to avoid. So first, to talk about how the data was acquired, as part of my K-23 that I got funded on a few years ago, I was able to add this questionnaire into the OAI. At the time of the funding of the project, the OAI had already started the 96-month visit, so I wasn't able to capture everybody. But as soon as the questionnaire was approved by the OAI Coordinating Center and the OAI site PIs, then it was administered. So the questionnaire that we put in was basically modeled after this historical physical activity instrument that was initially created by Andrea Kriska and published in the American Journal of Epidemiology in 1988. And this questionnaire was originally designed to evaluate the relationship between physical activity and bone health or osteoporosis. At that time, it was orally administered, and when we were talking about it within the OAI, it was felt like the administration of it in that manner would be too burdensome. And so what we did was we converted it to a self-administered format. And this has also been previously done by this other author, also published in the same journal, but later in 2002. So what we did was we incorporated our questionnaire into the take-home questionnaire that was sent home prior to the 96-month visit. And we asked participants to complete that before their in-person visit. And they brought that questionnaire to that visit, and then the OAI staff would check for completion of the questionnaire. And if it wasn't completed, they would assist the participants in finishing it. So where is this data now? So the OAI knowledge base is all about helping people to understand how to get this data. So I thought it'd be helpful to kind of walk through exactly how we can look at this information. And this particular data is a little complicated, so I do think that understanding this process will help you understand how to look at many other types of data as well. So the data for the OAI, for the clinical and the radiologic imaging, is stored at this particular URL. It's hosted by the NDA, and if you use this QR code, that will also take you there. So this is what this website looks like, and it hosts many other data sets as well, but ours is the OAI. So you would just click up here, and this would take you to the Osteoarthritis Initiative. You do have to create an account, which actually doesn't take very long, except for the login.gov part, which is painful on many levels. I'm sure everybody knows about that. But anyway, once you have an account, then you can have access to this. But when you get to this page, this is the tab that I think is most useful. So you would click on this, and I know that knee-jerk reaction would be to want to go straight to downloading the complete data sets, but I'm actually encouraging that you take a step before that and to look at the download documentation, because I think this actually makes it much clearer how to interpret the variables that are available to you. So when you click on that, this will take you to a bunch of options, but this is the one that I'm advocating for, is that you look at the annotated questionnaires. And so you will click on this, and that will take you to this compressed zip file, and then you can unzip it, and then you have all these options. And I'm not saying that you have to download all of them, but it actually does download super fast. But the one of relevance for the Lifetime Leisure Physical Activity Questionnaire is this one, the 96-month take-home questionnaire. So the good news is that the labeling for the for the files is actually very intuitive, and I think you can kind of figure out which ones you need. So we'll take a look at this one. So I'm not going to show you that entire file, but what I did was I took us to where the physical activity questionnaire is. And I do think it's very important that you understand what was in the questionnaire that people read prior to actually completing the questionnaire, because it does help dictate understanding for how they answered what they answered. So I'm not going to read this whole thing to you, but the main gist here is what is underlined here is that we looked at people, or we asked people to really think about the activities that they did over a lifetime, but to only consider activities that they did for at least 20 minutes within a given day. And they didn't have to be consecutive minutes. They could be broken up over a day, and they had to do it at least 10 times in their lives. And they were also asked to include activities done during a physical education class. So this is the beginning part of the list. So there in total were 37 activities that we asked about, and this is alphabetized. This is not based on, sort of an activity we're more interested in. Just to keep it simple, we did list it in alphabetical order. So the activities are listed here, and then the age ranges are listed here. So what we did was we broke it down into 4 different age ranges: 12 to 18, 19 to 34, 35 to 49, and then ages 50 and older. So then what we had them do at this part was actually very simple. Just mark in the little bubble if they actually did the activities during those age ranges. And it had to meet the criteria that we just talked about before. So these are the full 37 activities. And you don't have to like take a picture of them, because you can always download this file by yourself on your own and look at it as much as you like. But these were activities that I was interested in, or that were on a prior questionnaire, and we thought were of particular relevance. Okay, so then after people completed this, then we got to the next part of the questionnaire, which is question 37. And what we did was we wanted to get more granular information as far as the amount that people participated in the activities. So first here, we're looking at ages 12 to 18. And what we wanted to do was to ask people to look and think about the top 3 activities that they participated in during that age range. And then they would mark down the activity code based on what we showed on the previous 37. They would list the activity code here, and they would write down the activity that it represented. And they would do that for, as I said, for the top 3 activities. Then, okay, this looks really busy, but if you know that question 37 came here, like everything that you wrote over there on question 37 just came straight right here. And what we're doing then is we're trying to get more information about each of the individual activities that they listed on the prior page, right? So we have question A, B, C, and D. And here are the answers, right? A, B, C, and D. So what we did was we wanted to know how many years in that age range between 12 and 18 did they participate in the activity. And so we broke it down in this way so that people didn't have to think too hard about which one they had to pick, so they didn't have to be super exact. And we did this for all of the questions here. So we looked at the number of years that people participated in the activity, and then we looked at the number of months per year they participated, and then the number of times per month. And this allowed us to come up with a quasi-mathematical equation of how many times people participated in the activity during that time frame. And then we asked people to just answer if they participated in the activity competitively. And this was not anything that we gave any specific directions on, just what we have listed here. We specifically said, actually, it does not mean that you have to have participated in organized competitions, but that you participated on a competitive level. So this was self-administered. People just kind of took that for what it was. So after people answered all of these questions for the first activity, they would also do it for the second and the third activity similarly. So then the next question, we still looked at the same age range of 12 to 18, but then we asked about walking for exercise because we were particularly interested in that. So you do have to bear in mind that when we look at walking, it's not necessarily listed as a top three activity. But we did ask similar questions related to if they did it or not, and then how many years they did it during that time frame, how many months per year, and then times per month. And again, this allowed a way to quantitate the amount that people participate in the activity. So I just walked through all that part of the questionnaire, and then I just wanted you to understand the way that the questionnaire was laid out, but then I want you now to understand that there is grayed out lettering of the variables that are used to store the responses. So this is really important because the way that this document is most useful is that if you can understand which variables are associated with which questions. So I just pulled one of the questionnaires back. What you see here, so right here, you can see that there's this grayed out thing that's really hard to read. So I'm circling it for us here. And you can see this says AC1, AR1. So if you're looking for this particular variable in the data set, what you'll do is you'll look at the all clinical 10 data set, or I mean, actually, I'll get to that in a minute, I think. Oh, no, I think I already said that. Anyway, but this is at visit 10, so V10, which is the 96-month visit. And so the variable name within the all clinical 10 data set will be V10, AC1, AR1. And then you'll know that that is what the activity code is for this first activity. And then if you look closely, there are lots of other grayed out variables. And this is how you can use the data when you write your own program or your programmer writes it for you. But it's important to see all these gray notations to know how to access the data. Oh, okay. So this part is the all clinical part. So now we can get to downloading the complete data sets. And so I got ahead of myself a little bit, but what you would do here is that you would click this button, and that would take you to this menu here. And I recommend using this all clinical data set. So I personally use SAS for programming, so this is the one that I would choose. And as I mentioned a little early before, is that the data set of relevance is the all clinical 10 data set. That's where the data for the lifetime leisure physical activity is located. Okay, so now that I've talked about what it looks like, what can be done with the data? So in the time that I've used this data, there are two general strategies that make sense to me that I have personally used. So the first strategy really looks at the exposures at different lifetimes certain times in life in those four different age ranges or cumulatively over time, and then look at the associations with the outcomes in the OAI cross-sectionally. And when we're doing this, we're basically using the outcomes cross-sectionally as surrogates for a cumulative incidence of disease and symptoms. So obviously for knee osteoarthritis. Okay, so I show this as an example because I think it's easier if we talk about a specific project that we looked at this data to understand what I'm talking about. So this was the first paper that we published looking at the association between running and knee osteoarthritis that was published in ACNR in 2017, 9 years ago. Anyway, so in this table, this really represents what I was suggesting on the prior slide in terms of the analytic strategy. So what we look at, and so although this is kind of busy, I think it is important to look at the whole table. In this first group of analyses in this top row, we're looking at running over a lifetime. And then below that, we look at the different age ranges. So we're looking at ages 12 to 18, and then ages 19 to 34, ages 35 to 49, and then ages 50 and older. And really the arrangement of the data here is the same in each age range, except that the age range of interest is different. So then I thought we would look at this top row and I'd walk you through that. So what we have here is looking at lifetime running. And so what we did was we compared people who were runners to those who were non-runners. And we looked at the prevalence of frequent knee pain. And what you see is that the people who were runners were less likely to have frequent knee pain compared to the non-runners. And this resulted in an unadjusted odds ratio of 0.78. And this was statistically significant. And when we adjusted for age, sex, BMI, and other activities that also associated with running, the finding was robust, and it still remains statistically significant. So after we looked at this relationship dichotomously, then we looked at a dose response. So what we did was we took all that information that we talked about earlier that allowed us to know the number of times that people participated in the activity. And then we broke them down into different groups based on the number of times they participated. So the people who are in this high group participated in running the most often. And so what we see is that the prevalence of frequent knee pain is the lowest in the people who ran the most. And this resulted in an unadjusted odds ratio that is 0.65, and this was statistically significant. And this was also stayed statistically significant despite adjusting for age, sex, BMI, and other activities that are associated with running. And then we looked at the other outcomes of interest. So basically, this table is the same arrangement, but now we're looking at radiographic evidence of a disease. And in this instance, we were able to see that there was actually less radiographic evidence of osteoarthritis, but this only remains statistically significant in the unadjusted odds ratio, but for the adjusted, this was no longer significant. So, in our first group of analyses, we included BMI as one of the covariates that we adjusted for. There's a lot of controversy on whether or not we should include BMI as a covariate, because if it's on the causal pathway, then maybe we shouldn't. So anyway. But I think that it's important to understand that when you're interpreting the data here. And then we also then looked at the relationship of these exposures with the combined outcome of both symptoms, being frequent knee pain, and radiographic evidence of disease within the same knee. And we saw a similar arrangement. And in this instance, again, it was statistically significant in this highest group that people were less likely to have this outcome if they were in this high group of running, or even actually just dichotomously. But once you adjusted for all of the covariates, then it was no longer statistically significant. So, so the strengths of this approach include that the Osteoarthritis Initiative has the only data set that we're aware of that has information on lifetime leisure physical activity on people who are not selected based on their participation in those activities. And so this allows us to really look at people who participate in these activities on a much more recreational level, as opposed to much of the literature that exists really focuses on people who participate in these activities at an elite level. They look at people who are Olympic athletes in these different sports. And that's less pertinent to the everyday person who is going for a run or, going bike riding. So I do think this is important in terms of generalizability of the studies that we're conducting. And the other strength of this study is that we really have very highly standardized measures of osteoarthritis. So the x-rays are very standard in the way that they're acquired and the way that they're read. The questions for symptoms are also very systematic and have a lot of historical use within osteoarthritis. So those are the strengths, but there are limitations to this approach. So one of the limitations is that we were not able to ascertain the entire cohort within the OAI, given the timing of the funding of the project. So the 96-month visit had already begun by the time that we were able to administer this questionnaire. So we didn't catch everybody, but we still got more than 2,600 people, and that's still a substantial number of participants who we do have data on. And the other important limitation is that the time point that we have the most central readings of radiographs that was proximate to the historical physical activity questionnaire administration, which was the 96-month visit, is the 48-month visit. So ideally, we would have liked, the exposure and the outcome to be at the same visit, but it's just not what it is. So they're not contemporaneous. It's not ideal, but as in many cohort studies, this kind of thing does happen. And so I think we just have to accept it for what it is. There are no other data sets really that I'm aware of that even has this level of data. So it's a good starting point from which to produce some data to provide as support for additional data that needs to be, or additional studies that need to be conducted down the line to further understand the relationship between these activities and then also knee osteoarthritis. So despite that, the time point for the outcome measures and the questionnaire are not contemporaneous, our participants were not aware of our hypotheses, and so they were unlikely to be biased in their responses on the physical activity questionnaire. So I do think that that is helpful. So, okay, so that's one approach to how to look at the data. And so the second approach is a little different. And so instead of using all of the data from the exposure, we really only look at ages 50 and over. So the point or the purpose of looking at that time frame is that that's around the age that people were enrolled into the OAI. And so looking at that exposure will help us to understand what their exposure is during the time frame that they were followed within the OAI. So this will allow some longitudinal evaluations. So again, I'm going to just walk through our second paper that we published that used this particular strategy. And again, we were looking at running. And so because this is a longitudinal evaluation now, not just cross-sectional, what we're looking at is from baseline to the follow-up visit, which we have the most amount of information on. So that's the baseline to the 48-month visit. We look at these different outcomes of interest. So in this instance, we were looking at Kellgren and Lawrence worsening. And when we compared runners to non-runners, we saw that the outcomes were about the same. And this resulted in unadjusted and adjusted odds ratios that were not statistically significant. And you'll notice that we only did dichotomous outcomes here because the amount of participation of running in this particular group was smaller. So, you can really only do this like breaking out into smaller groups if there are enough people who are participating in the particular activity at the age range of interest. Then we looked at medial joint space narrowing worsening, and this was also about the same. It was not, the odds ratios were not statistically significant. And then when we looked at the development of frequent knee pain, and so in this instance, it's important to understand that in order to develop frequent knee pain, then you had to be free of frequent knee pain at their baseline visit, and then you would have developed frequent knee pain at the 48-month visit. And what we see is that this prevalence was also about the same. And again, the odds ratios were not statistically significant. So I think this is actually the most interesting part of this particular analysis is that in this analysis where there was improvement of frequent knee pain, so that means that at their baseline visit, they had to have answered affirmative to the frequent knee pain question. Then by the 48-month visit, they had answered no to the frequent knee pain question. The people who were runners were far more likely to answer or to have this particular outcome compared to the non-runners. And this resulted in an unadjusted odds ratio of 1.6, meaning that runners were more likely to have this arrangement compared to non-runners, and this was statistically significant even in the adjusted models. So this was actually really reassuring to people. There's always been this concern about running being harmful to people with osteoarthritis, and so this really help to allay people's concern that that it did not appear harmful, and it could even be potentially beneficial. Although, the number of people in this particular group was not as large as in the other group, but I do think it was very reassuring. It is also important to know that these are observational studies, and so people are not randomized into these into these groups. These are self-selected runners, and this goes for any kind of analysis that you would do, that these are all self-selected um, people who are self-selecting to participate in the activities of interest. And so you have to bear that in mind when you're making interpretations for the findings that you see. So I just gave you a little taste of how to use the data, and you can see that we've already looked at running. There are other activities that we've looked at so far, and that includes strength training, swimming, bicycling, American football, gardening, walking, baseball, basketball, and tennis. So, I mean, there's obviously much more that can be done. Some of what we have done has been driven by activities that people have more participation in and that there's more interest in knowing about. But some of the activities are too low in frequency to really study. Um, and then the final thing that I wanted to say in our talk, this is my final slide here, is really a recommendation of what not to do. So I think there's this knee-jerk reaction to want to compare people who do one kind of activity against people who do another kind of activity. And because of the way that we have administered this questionnaire, I really don't think it's a good strategy, because a person who swims could also be a person who runs. And then you're comparing that person against him or herself. And that conceptually doesn't seem appropriate. So it's a much better approach to look at one activity at a time, comparing those who participate in the activity to those who don't, or comparing those who participate at a higher level in that activity to those who participate either at a lower level or do not participate in the activity. So that's the end of my talk, and I'm happy to take questions, but we're taking a little hiatus for our webinar for the summer, and we will come back in the fall. And this is a QR code for our OAI knowledge base, and check there for updates.
Great. Thank you so much, Dr. Lowe, for that great talk. Yeah, we have a couple minutes for Q&A, so if anyone has a question, you can type it into the chat. I have a question for you here. How do you handle a history of injury which could be caused by an activity or influence what activities someone participates in?
That's a good question. So the question about injury is not directly in the leisure physical activity questionnaire, but we do have questions about injury in the main data set. So there's a question about, like, have you injured yourself, injured your knee that has led to not being able to walk for 2 or more days? I think that's the question. I don't know exactly the wording of it, but basically it asks if you've had an injury that would sort of qualify as that. And then there's actually one question that asks for age 25 and younger, and then at the time of entry into the OAI, it also asks a similar question. So I can't like connect the two directly, like, hey, this person had an injury from baseball, but I can say, hey, the person had an injury at this age range, or not.
Another question. The survey may be long for some people. Did most people who started the survey finish their survey?
That's a good question. So it was a take-home questionnaire. So I don't know how many people needed help when they when they came to the 96-month visit. That was just our strategy of trying to increase participation in the completing the survey. Um, I don't remember offhand exactly how many didn't complete it, but there were some people who attended the 96-month visit and then didn't complete the survey. But if you look at any of our papers, we do give like a little flow diagram of how many did not complete it. I want to say it was maybe like 15%, something like that. But don't quote me on it.
Okay. Thank you for that. I guess that's about all the time we have for today. So thank you again, Dr. Lowe, for your excellent presentation. And thank you all for joining us today. As Dr. Lowe mentioned, we will be taking the summer off, but we'll resume the webinar series again in the fall. So keep an eye out for the update. I sent some links in the chat for you to keep up with us and also a link to the post-webinar survey. And so that's all we have. And thank you again and hope to see you in the fall.
Thank you.